for the wait, everyone. Thanks so much for coming. We have a bit less time than we anticipated, but we'll be just fine. And I can stay a few minutes afterward if you have any questions or anything. So I am here to talk about this topic, which came out of my master's research. And what I'm looking at today is undergraduate nursing students' experiences in their mental health practicums. And this is from the qualitative narrative inquiry study that I did out of my master's with these folks. So I put their pictures up here because for some of you, you may have seen them around the department, but not necessarily put a face to the name. So this was my committee. Vicki and Emily, who is able to be here today, thanks, were my co-supervisors. And then I also worked with Helen Brown. So they were very much contributors to this. So I just wanted to acknowledge them right off the bat, even though I'm the one talking today. So today I'm going to talk a little bit about why I came to the study and what sort of the need is in terms of focusing on mental health practicums. Then I'll talk to you a bit about what we did for the study and then focus the bulk of our time on the study findings, which we're kind of centering around this idea of power and resistance. And then I'll talk about implications for practice in a shorter amount of time, and then focus a bit on educators and students because that is who's here today. So do I need to worry about that beeping, Marilyn? Okay, great. So how I personally came to this study is that my background is in mental health nursing, and so I graduated from this program, did my undergraduate degree here, and I came to mental health nursing through the practicum. I had absolutely no idea I wanted to do mental health. I thought I would hate it, and then through the practicum I came to really get a lot out of it and end up an inpatient. So that sort of got me thinking about that practicum experience and what it means to different people and how it can change minds or not, and the kind of interesting ways in which that may or may not happen for someone broader than, population broader than myself. And then I became a clinical instructor in the school and did that for a number of years. And I was teaching within the 335 mental health course. So saw a lot of students come through and spoke to them before the practicum, was obviously with them throughout the practicum, and then sometimes had the experience to connect with them afterwards. And I just started to think a lot more about the different ways that presented for people. So I really wanted to translate that into research after seeing a bit what was out there. So what I mean by identifying downstream challenges is seeing what can happen very much downstream from where we are in education and seeing some of the mental health outcomes and thinking about how we can potentially use the mental health practicum as this great education and experience opportunity to start to address some of those concerns. So that's what I'm going to talk about first, which is we know there's a huge need for mental health care in Canada and globally, and often a need that is not being met. So this is a kind of global picture, which is that up to 85% of individuals with mental health care needs globally don't receive any treatment, which seems very high, but even within Canada, 17% of Canadians report a need for mental health care, but in fact, a small, relatively small amount of that is met. So this was from a kind of Canada-wide, quite large-scale survey, and a lot of Canadians are saying that their mental health needs are not met by current mental health services. And I think a lot of us would agree that nurses have such an important role to fill there, and there's so much that we could be doing to help address this 33%, but how much are we doing that? And obviously we have to address this issue from a lot of different angles, but certainly education is one of them, and how we are preparing students in our program to address mental health needs in mental health settings. But we know that, of course, this 33% may not all need inpatient mental health care, which is where a lot of our practicums are located. But how can we prepare students to anywhere in any practice setting in the community or in hospital start to address these needs? So I think there are a lot of possibilities for nursing, but the statistic in some ways points to the fact that we could be doing a bit more. So one of the gaps, I think, between the need for mental health care and that need being met is certainly stigma and discrimination, which I think we're all very aware of, so I won't go into it a lot, but there's certainly widespread mental health stigma, and almost half of Canadians in the general population say that they would not associate with a friend who has any kind of mental illness, which is staggering. And we also know that stigma is often greater for individuals who have sought mental health care in any form than for those who haven't. So there's that barrier as well to even seeking treatment in the first place, let alone what that kind of care comes to actually look like when it's provided. A lot of the general population, as well as nurses, have this fear that individuals with any kind of mental health challenge might be violent or unpredictable. So that creates some of that distance between kind of us and them, as we like to think of it, though of course we all know that that's not really a useful framework for thinking about mental health care, but we tend to get into that mindset. All of the mental health care we provide is within this previous context of institutionalization, and a lot of those stigmas kind of draw through into today. So the era when we had, which was not that long ago, when we had asylums or kind of institutions where people were very much segregated from the population, and it was seen as a kind of dark and fearful place in many ways. And for the people who were there, in many ways it was, but for the general population thinking about those places, it was that a lot of that fear was located in the kind of patients or the people who were there. So that context kind of comes back into play in some of the findings. So I just wanted to put it out in front there. Unfortunately, in terms of the limited studies that have been done, it does seem that in many of these ways, nurses' attitudes toward individuals with mental health challenges are comparable to this general public opinion that we get. So fear of violence and unpredictability, and just general stigma towards seeking care. And this holds true both for nurses who are working in general settings and those who are working in mental health settings. So that is a bit of a concern, and speaks again, I think, to the importance of this practicum experience, at least for our nurses, and sort of how we can start to address some of those challenges that might not be met in the practicum that are leading to this ongoing stigma in the nursing population, or ways in which what they call residual stigmas are still kind of existing after the practicum, and how we can shift the way that we're delivering these practicums to maybe look at that. So that's kind of part of where I came to nursing student preparation and the role of that. So nursing students often do experience the practicum as a distressing and a difficult time. And that may not hold true for every student, for sure, but overall, students find it quite challenging to be in this practicum. Following the clinical experience, students don't typically feel adequately prepared and are not ready to go into practice either within a mental health setting, or aren't prepared to work with individuals with mental health challenges anywhere across any setting. So there's an issue of kind of skills, knowledge, overall feeling of competence, but also students often self-assess that there is an attitude concern, that they just don't feel always prepared from a sort of attitude or perspective sense to work with this population. Mental health nursing, and most of the studies are located here in terms of career. And so one of the reasons I wanted to do this was to broaden out the discussion a little bit, but across almost all of those studies globally, mental health nursing is seen as the least desirable career path. So this often comes out of survey work where students are asked to rank the various professions, and at almost every point throughout their nursing school trajectory, mental health nursing is last. So not only do we maybe want people to go into mental health nursing, but also what does that reveal in terms of how mental health in general is perceived, and looking at caring for individuals with mental health challenges anywhere. The fact that it's last needs to be looked at, I think. So in summary, why I kind of came to this topic is that gaps in mental health nursing education can so easily lead to gaps in mental health care. And so what we can start to do from the educational side to help prepare nursing students and what the experiences really are. So these are some of my study aims. Basically, there was a lot of quantitative research. There was a lot of research looking at career preferences. There was some research looking at student experiences in a more qualitative way. It was often focused. So sometimes it was focused on students who were not interested at all in going on in mental health nursing, or it was focused on particular aspects of nursing students' experience. So we hadn't really had the opportunity to just gather student stories about what it really is like to be in a mental health practicum and see what comes out of that. So that was the main aim, to get students' experiences, but then really look at it in context. So social context and context of the institutions where they might be going to take these practicums, in context of their own previous experiences and beliefs. So that's what we sort of set out to do. And because of that aim, we took the theoretical approach of power and resistance. So part of coming to this was that we did want to take a more critical approach, knowing that the stigma is there and that this history of institutionalization continues to inform how mental health care is delivered now. But also this came partly out of the first few interviews that we started to do, and really seeing some of these themes run through, and then starting to think about that in a kind of more theoretical way. So I won't spend a ton of time on this, but just to say that we looked at power in terms of a more Foucauldian perspective, that power is everywhere, but it's enacted through individuals. So that though individuals kind of do have power over others to a degree in our society, that also power is part of the system and kind of part of our general social landscape, and how that's enacted is through these tiny everyday mechanisms, so what Foucault calls micropower. So we were very interested in how students spoke to power as just happening in the everyday. So these little moments in their practicums that stood out, that were then retold in the interviews that we did, we'll talk about in a minute, and how those little everyday moments of power all came together to kind of form the narrative of what was going on in these practicums. So you'll see that kind of threaded through a lot of the findings. I'll come back to that at the end. But that alongside this power and how power can be within these institutions and can really deeply affect the everyday lives of both patients who are in our mental health settings and students, that there's also this opportunity for resistance within that. So Foucault says that where there is power, there is resistance, and this certainly came across in what we were looking at in terms of students' experiences, but it was also something that we thought was really important to recognize, that there are a lot of studies and there's a lot of knowledge that mental health care can be a place where power is enacted and stigmas are perpetuated, but that also we wanted to look for places where students and patients in their stories could be empowered. So we didn't just want to reproduce, oh yes, there's a lot of kind of power out there and stigma certainly exists. We wanted to look for places where that was interrupted. So that's kind of how we came to the data. So what we did was, this was a narrative inquiry study, and what that meant was that we were looking at the individual's narratives or their stories, and that we were treating their stories as data. And so while we were certainly ultimately looking at themes and what kind of came out of that qualitative data, that we were interested in how a student's narrative also held narratives that are in society, that are in nursing, and kind of all those different layers of story, and how one person's story can give us a window into all of those different narratives. So as you can see, we took a bit of a critical slant on that, looking at power and how power is reproduced in mental health settings. And to that end, we did individual interviews. So it was with our population, which is why I think it's partly so important to talk about this today, and why I'm really glad that so many of you were able to come, even though I know there were competing meetings, because this was our population. So I think it gives us a lot to think about in terms of our nursing school. So I spoke to 15 participants, and all of them were in their final 4 months of nursing school. So they'd all had the practicum, obviously, and they had completed it at different times throughout the year, which I'll speak about, and they were at that point in their avenues in preceptorship. So they were at a really nice point of reflecting back on their experiences, but they were recent enough that they could sort of recall the highlights, but they had certainly progressed in terms of their nursing school trajectory, and in most cases had a bit of distance from that practicum, and were able to think about it also in relation to other practicums and other nursing school experiences, and sort of reflect on what had happened then. So it's a brief summary of who we spoke to. The age is obviously the age range, and the average is a little bit higher, but of course that reflects our population, which we know pretty well from the BSN program. It might look different from other nursing schools demographics, but it's more or less, I think, reflective of where we are. Similarly with gender. These clinical sites, so as we all know, we typically in the kind of 300 rotations have 3 sites often that students are divided between. So it was a bit skewed for sure toward site A, but some representation from the others, which made a kind of useful comparison point to make sure that this was not just one site. And so we did a bit of kind of trying to seek out people who had come from different clinical sites to make sure that we were getting the full picture. However, quite a nice spread across the rotations. So some students had, by the time they spoke to me, had done their mental health practicum almost a year ago. They'd completed it in rotations A and B, and some, it was quite recent. They'd completed it just a couple weeks ago, really. So we had a nice spread there. All right. Any questions at this point before I jump into findings? Okay, great. So students spoke almost universally about the mental health practicum being fundamentally different for them than other practicums in terms of preparation and preparing to go into the setting, which was not something that we necessarily expected, but for students seemed almost kind of a given that it was quite different. So students were often anticipating what the mental health practicum would be like up to a year in advance and preparing for it actively by speaking to other people in the program, speaking to other practicing nurses or nurses who had completed the program in advance, and put a lot of time and emotional effort into getting themselves ready for what this practicum would be like. And a lot of that came in the form of anticipating challenges and putting systems in place to manage well-being. So though there may have been some excitement to go into the mental health practicum for some, a lot of that also included expectations that it might be difficult for a lot of different reasons. For some, it was having almost no experience and not being sure what to expect and trying to filter through these kind of social messages about what working with individuals with mental health challenges is like. And for others, it was having a very close, sometimes themselves, very personal or close friend or family member experience of mental health challenges and trying to sort out how that experience would reflect in the mental health practicum. So for a lot of people, for different reasons, they were coming to it with a similar kind of perspective, which was, how am I going to sort of handle on an emotional and sometimes psychological level this experience? So one person said, I have a history of a bit of depression, and I had the sense of, to hell with patience, I'm going to do whatever doesn't trigger me. And that didn't bear out. And certainly this person was not trying to come in with a not patient-centered view, but that was this person's way of describing this undercurrent of concern and worry about what the practicum would be like and what they might have to do to protect themselves in that practicum. And this is quite a different perspective than one might come to, for example, maternity with in many cases, not always, but another person said, I've heard people saying, so others who had done a mental health practicum or other nurses, that they were exhausted all the time emotionally within the practicum. So it's just thinking, what can I do to set my systems in place in advance? And spent a lot of time speaking to counselors, friends, family members about what those systems would be, and in fact put detailed, sometimes written down systems into place to prepare, which was very different than the preparation for other clinical practicums, where mostly they just started on day one. Another part of this pre-engagement, though, with the practicum was not just managing sort of personal worries and concerns about the upcoming practicum, but also resisting stereotypes that had been circulating just in media and the person's social circles, family, and trying to already, before even starting the practicum and before starting the course content, the theoretical class content, think about the practicum in a different way than some of their underlying kind of internal messaging was prompting them to. So this one person, they had spoken to a friend who had done the nursing program previously, and on that friend's very first day of the mental health practicum had unfortunately experienced a kind of personal physical attack from a patient and had told this participant that story. And this participant, despite kind of this circulating fear of unpredictability and violence that can be in media and can be in a lot of the stories that travel in society, this person said, oh, I think those stories do just travel. I think people think mental health and sometimes they think aggression, but this person went on to say that could have happened in med-surg, that could have happened in maternity from someone who was giving birth. So that's just something that happens. Everyone has a funny story in nursing school, and that was just this person's funny story, and that's what happened. And so really resisted taking it up as, oh, that proves everything that I've ever thought, that people are, you know, aggressive and violent in these settings and I have cause to be afraid. This person in some ways did brush it off and thought, oh, that's just what happens. So that was one person's perspective, but in many ways, people were trying to separate these societal narratives from what they wanted to go in with. So others were saying, oh yeah, we've all seen media, but I just tried to go in with a blank slate and just tried to accept what would come. So though there was this fear, there was also this resistance at the same time, which I thought was, you know, was notable. And that in many ways continued on in terms of entering the practicum. So nursing students, when they came in and were actually kind of there and taking in their first impressions, identified that power was operating in this setting. And so it's what we are calling recognition as a form of resistance. So recognizing that power was there and recognizing that practices were not always ethical was in and of itself, without kind of action as we would typically think of resistance, even without a kind of physical or overt action, just recognizing that power operated was resistance in this setting. So there are a few ways in which that's happened. So the first way that kind of recognizing power operated was seeing nursing staff disengage from clients and recognizing that this was a concern and this wasn't how students expected it would be or how they believed it should be. So in an example of this student was talking about their very first day on the mental health inpatient unit where they were for the practicum and how they were sitting in morning report. It was the kind of first 5 minutes this person was on shift. And the student says, I remember being so shocked. One nurse said, oh, do we have to? And then the group of them were saying, let's just sit here for 5 minutes. And the student in surprise said, and they just sat there. I was so confused, but that was the whole day. Do we have to go down the hallway and do this right now? And they reflected that, oh, I thought at first it was just, maybe they're tired, maybe, this is just their start to the day, but it carried through the whole day. This constant disengagement from clients. And this person said it was nothing like med-surg. It was not at all what I expected. I was shocked. I was confused. I didn't know why that disengagement was happening. Students spoke about this being constant really across a lot of their different environments, with some individual exceptions, of course, always certain nurses doing such a fantastic job, but a lot of students actually said, I didn't have role models. I didn't know how to approach my clients because I didn't see it happening. One student estimated that about 30% of nurses' time was spent doing anything client related. So that included documentation, pouring medications, not just actual kind of person-to-person engagement, but that the other 70% of the time was spent on social media, applying for other jobs, just really not kind of engaged with the profession. And that was a shocker for our students. But the fact that it was shocking speaks to the fact that there was that recognition there, that this wasn't kind of acceptable or to be expected. And then even above disengagement, students recognize power in the way that nurses were often treating patients. So identifying instances of unsafe, unethical practice, and in recounting them and thinking this is a story that I need to tell in this interview because it wasn't right, recognizing ways in which power operated there. So this one student speaks about a client that she worked with quite extensively throughout her rotation who was First Nations, and she remembers one day she was very upset because they, the nursing staff, had got the pastor to come and talk to her, and no one put the dots together on that one, that it might be so triggering for someone who has intergenerational trauma. There isn't a lot of talking to patients to be like, so what would actually help you right now? There was just decision-making often on the part of the nurses. Another student told a scenario of the nurses using all of the available PRN medications on the MAR all at once because the student's perspective was that this person was upset. The nurses didn't have kind of time or emotional space for that engagement, and so utilized all the PRNs at once, and the person was asleep for the rest of the 12-hour shift. So there were ways in which kind of this disengagement and the way that practices occurred on the unit were recognized by students as a power relationship. Okay. So in the context of this, students said, I didn't have a lot of direction in terms of what to do. I learned the gaps, one student said, and I learned what not to do, but I didn't always know how to practice because I wasn't seeing it role modeled for me. So students then found other ways of determining how to practice in this space, which we've called enacting resistance, so acting differently than what was being seen on the unit. So in one way, and the most kind of foundational and, in my mind, powerful way, was connecting as a means of resisting the power on the unit. So students connecting with their clients, despite often verbal disagreement with their practices, was a form of resisting that power. So one student said, initially it took me a couple of weeks to be comfortable, to be like, okay, I'm not doing anything. I gave all their meds. I did my charting. I don't need to look at my Facebook. So why not just go talk to them? But at first it was almost hard for the student to think that that would be an acceptable thing, to just go talk to clients because it wasn't happening on the unit. Another participant said, I was with this one patient the whole 6 weeks, and I would go into his room and we'd be having conversations. And at one point I came out of the room and the nurse said, why were you in there? It's been like 45 minutes. And I didn't have any other patients at the time. And he was telling me about his story, things that weren't in the chart. And she was just so demeaning toward me for it. So students were often not only picking up on a vibe or a kind of different way of role modeling that talking to patients was not usual, but sometimes, and more than just this case, were actively reprimanded for spending too much time with clients or not spending time in the right ways. So students came up with ways of connecting, playing board games, socializing, getting a group together to chat, doing impromptu groups, just finding other ways to connect, even though they weren't able to see that. I thought this would be a particularly kind of interesting point for some of the educators in the room, I guess, which is that students also picked up on other ways of knowing and drawing those ways of knowing into the clinical setting. So while they were not always able to identify role models to emulate, which we often think of as the purpose of a practicum, to see care in action, students picked up on other perspectives, and that was often from the classroom as well as from the clinical instructors. So one student said, I think relational practice is something that's very ingrained in us, which I think we can say is very true in our program, and it came out here. So I went into it, the practicum, knowing that I should interact more with my patient, and I like to, so it wasn't forced. I just feel like that's the best way to care for them, and I didn't see that from the other nurses that were already there. So despite not seeing it, having been taught it in the classroom setting, the student thought this is something that I need to utilize to inform my practice, which I think is just so powerful as educators. I think that's just great, and what we really can start to think about in terms of how we can prepare students and support students. Students also, and I think we've all thought about this a little bit or sometimes used it ourselves, using the student role as a justification. One student said, oh, I'm just a nursing student, so I'm just going to do it this way, and proceeded to do it in a way that they thought was right and use the student role as a bit of a cover for that. The student actually called it the veil of academia, and just using that veil to proceed in any way that they thought they should, but be able to do that in a bit more of a kind of non-confrontational way with the nurses who might have been acting differently and may indeed reprimand them. So the student went on to say, I was actually trying to be more critical and weave through what I'd like to adopt in my practice and what I'd like to leave out of my practice, but I just framed that as, oh, I'm just a student, so I'm going to do it this way. But really, they were trying out, does this work? Does this work? So in those ways, they were not always explicit or overt resistance, but caring for patients in a way that differed from the norm often was framed as resistance for students who found it often very difficult to practice in a different way and were often reprimanded for practicing in a different way. However, at the same time, nursing students did not always articulate themselves as these sort of champions of relational practice or champions of best practices, but often articulated that their experience was one of disempowerment, and that though it may seem to some of us like these were amazing stories of going against what was being modeled, drawing in classroom content, drawing on clinical instructor support to really do mental health nursing in a different way, that was not always felt to the students who were actually in that setting. So students felt quite disempowered. They articulated within the practicum. One said, you don't want to impose, you don't want to draw attention to yourself, you're here to learn but don't cause waves. And others in the literature have called this don't rock the boat. So kind of a similar perspective, but students were very concerned about this making waves with the nurses, and we're often trying to take up these more subtle strategies of connecting with the patient but covering it with the student role and not trying to often engage in overt conflict or engage in practices that would sort of raise that explicit conflict with the nurses, but do it in a very kind of under the surface way, but that often felt then like disempowerment and didn't really always read to the student as an empowering moment for themselves or for their clients. Students also articulated feeling disempowered when they thought about future nursing practice. So many articulated it's easy to get brought down by a negative unit culture. And one student told a story of witnessing an employed student nurse on the unit who kind of came in on their first day. They happened to be there at the beginning of both of their kind of respective stays on the unit. And the student describes witnessing the employed student nurse start to take up many of these, in the student's opinion, harmful practices over the many weeks that they were there. And after seeing that, thought, I cannot go into mental health nursing because that might happen to me. And many students, almost our whole sample, articulated, I cannot go into mental health nursing because I might start to take up some of these practices that I don't believe are safe, ethical, or engaged with clients. So I will not pursue mental health inpatient nursing. So I don't go into this kind of extensively in this presentation. I've talked about it a bit more elsewhere, but it does shed a lot of light on all of these surveys that were done that consistently put mental health nursing last And we like to think, oh, it must be that students themselves hold a lot of stigma, or we aren't appropriately preparing students in terms of skills to prepare to work with this population, which may also be true, but this is a sort of alternate and important way to think about it, which is what culture are students going into in their practicums, and what are they expecting in terms of their practice when they graduate, and what are the barriers to students coming in to this work environment, and do students feel prepared to work in that environment, their own competency aside. So for practice, the intention, of course, of this whole presentation is not to point to individual nurses who might have been in our student practicum settings and say that those nurses are practicing poorly. That may be the case, that in certain instances it really is sort of this unsafe and unethical practice that might need to be looked at from the practice setting. But we also know that with the history of mental health care and where mental health care systems are at now, we can see from our students, it's very hard to practice in a different way than these systems are kind of set up to create. So stigmatizing nursing practices certainly do happen, and the way that those filter into these sort of everyday mechanisms of power that Foucault talks about are, in my opinion, really important to look at. We have to think about where we are sending our students and the environment that students are going into and how power operates there, but also think about how our systems might remain, as they say, institutionalized, despite the fact that we say deinstitutionalization happened decades ago. So what they mean by that are, what are ways in which the system restricts power of patients, even aside from nurses? So, for example, framing going for a 10-minute cigarette break as a privilege. That's like a great example of how it's not an individual nurse's fault, or they're not necessarily enacting this unsafe, unethical practice at a personal level, but a way in which the system kind of frames that patient stay as the system holds power over that person. So again, this is not to necessarily blame individual nurses. We were only taking the student's perspective, but when we are sending students into an environment that has this history and has this present sort of institutionalized structure, what are students getting out of that, and how are we preparing students for that and supporting them? Which brings us to some of our sort of thoughts around nursing education and what those of us who are on the educator side of things can think about in terms of the mental health practicum for students. So first of all, now that we know that a lot of our students are thinking about the mental health practicum for weeks and months and sometimes more in advance, what can we put in place to prepare students for that, recognizing that they may indeed be thinking about it quite a lot earlier than we as educators have our minds set to it. So putting strategies in place for maintaining well-being during that practicum, and recognizing that those strategies might be different than are needed in other practicum settings. So to kind of give a small shout out to our other studies, self-care is certainly one of those things that we are putting in place, but not just thinking about that as a kind of general concept that will necessarily filter into ways of being in the mental health practicum, but also thinking about how our students might need specific knowledge, know what to expect, want to hear from people, and might want strategies specifically for sort of coping with that practicum. Also, this is a bit of a surprise for me, but also sort of heartening, emphasizing theoretical concepts. So a lot of students brought in trauma-informed care, relational practice, patient-centered care into the interviews, and spoke about how meaningful it was to have those theoretical concepts in mind during the practicum, but that sometimes it was hard to connect the dots between the theoretical concept and the practicum setting, and that clinical instructors were often that link. So how we're preparing clinical instructors to take up these theoretical concepts that we might be teaching in the classroom, or just how we're presenting them in the classroom, and whether that holds relevancy to the particular practicum. We might have taught it in, we're not calling this anymore, but a thread course, but how are we applying that to mental health? And are we asking students to always connect the dots themselves, or are we helping make some of those links so that in absence of a role model, we're kind of suggesting some practical strategies? Supporting clinical instructors. I didn't expect as a clinical instructor, anecdotally, that I would be sort of providing this level of support and debriefing and preparation, and I sort of came to learn that over my time. But also, a lot of our literature shows that clinical instructors don't necessarily see debriefing as a core part of the role, or aren't expecting this level of emotional support, which makes sense when we look at a lot of the other practicums. Not that debriefing isn't needed there and emotional support isn't needed there, but it takes a bit of a different form. So do our clinical instructors anticipate this and expect it. And lastly, for students, because I know that there are certainly some students here and you may have already had your mental health practicums, but just thinking about how this sort of applies to the student experience and then going into practice. So, of course, identifying supports, and from what we could tell in our sample, students are absolutely doing that, and that was, again, quite heartening to see. But anticipating the need for supports in advance was one of the best strategies that students could come up with. But also highlighting that many students did feel disempowered, but that we could see that disempowerment and empowerment were happening at the same time. And so how we can support students in recognizing their own empowerment in that setting and recognizing that some of the actions that they're taking really are meaningful and important and really represent this great nursing care that we're trying to talk about in our program, and just helping students see that to feel more prepared for the practicum and feel that their work is meaningful in the practicum. And one of those practical strategies being connecting with clients, that has a lot of meaning, and that doesn't just, it's not taken for granted necessarily, but it can be so powerful to patients and to students in that setting, even if it is against the sort of culture there. And lastly, it's a challenge for students, I think, to think about where they're going to work, for example, after graduating, and there's so many factors that go into it. But one factor that came up with a lot of students in our sample was, do I go to a setting where I know I'm going to be supported, or do I go to somewhere where I think I can make change? And it's an impossible, there's no right answer. It's really an impossible question, but recognizing that it is a question was a big kind of driver in decision making for a lot of students. And a lot of students end up saying, I can make change later, but I really need to get a grounding first, which is of course so reasonable, and we all want to be in supportive settings, and no one would ever say that a student should go somewhere where they have to sort of be this lone resistor in a difficult culture. But recognizing that it is a question perhaps on some of our students' minds, and starting to think about how to decision make around that with all of these other factors that go into career decision making, I think is an important one, and providing some support for students who are feeling concerned about that. So I just want to leave all of you with kind of one, it's long, I'll only read part of it, but one just fantastic quote from a participant in our study who was working with a client who would talk quite frequently about a lot of the traumatic experiences that she'd had in the past. And the student sought some support from a primary nurse about how to address this. And the primary nurse said, shut it right down, don't listen to it, don't acknowledge any of that trauma history, just redirect her. Basically, they'll deal with that in the community, was kind of the take-home message. And the student said, I'm happy to acknowledge your feelings, provide some supportive care. And they went back and forth on a little bit in conversation. And the student says, so we came to a compromise because I agreed, I'm not a counselor, it's true, but I am a nurse. And we can do therapeutic communication with people, and we can provide supportive listening and acknowledge people's feelings. And I just think that the student saying, but I am a nurse and I can do these things, is really at the core of our profession and at the core of what students can come to the practicum with and come out of the practicum with, and how we can support exactly this kind of ownership of our profession and ownership over patient care is, I think, what we're trying to do. So that's all I have. I know we're pretty tight on time now because we started a little bit late, but if anyone has any questions, I'd be happy to answer either in the big group or just